A 32-year-old male with Crohn's disease presents with chronic low back pain. I am showing you axial computed tomography scans of the pelvis and abdomen. Please describe the findings.
The pelvic computed tomography scan reveals bilateral, symmetric sacroiliitis, characterized by articular margin irregularity, periarticular sclerosis, and small erosions. Surgical staples are noted in the mid-pelvis. The abdominal computed tomography scan demonstrates thickening of loops of the small bowel, along with a subcutaneous scar from a prior ileostomy takedown, and absence of the ascending and descending colon, indicating a prior subtotal colectomy.
What is your primary diagnosis?
This is enteropathic spondyloarthropathy, specifically sacroiliitis associated with Crohn's disease.
Which inflammatory bowel diseases are most commonly associated with enteropathic spondyloarthropathy?
The two primary associations are Crohn's disease and ulcerative colitis. Spondyloarthropathy can also occur with Whipple's disease and intestinal bypass surgery.
How does the sacroiliitis in enteropathic spondyloarthropathy behave in relation to the bowel disease activity?
The sacroiliitis and spondylitis run an independent course from the bowel disease. They do not correlate with bowel disease flare-ups and do not improve following colectomy. In contrast, the peripheral arthritis associated with enteropathic arthritis does correlate with bowel disease activity.
What is the typical HLA-B27 association in patients with enteropathic spondyloarthropathy?
HLA-B27 is present in approximately 50 to 70% of patients with axial spondylitis, which is lower than the 90% association seen in idiopathic ankylosing spondylitis. However, HLA-B27 is not associated with peripheral enteropathic arthritis.
How does the radiological appearance of the spine and sacroiliac joints in this condition compare to ankylosing spondylitis?
The findings are radiographically identical, featuring symmetric sacroiliitis, squaring of the vertebral bodies, and thin marginal syndesmophytes leading to a bamboo spine appearance.
What is the key clinical differentiator between these two conditions if the spinal imaging is identical?
The differentiation is clinical, based on the presence of inflammatory bowel disease, bowel symptoms, or characteristic extra-intestinal manifestations.
What are the common extra-intestinal manifestations of inflammatory bowel disease that might be seen or reported?
Common manifestations include erythema nodosum, pyoderma gangrenosum, uveitis, episcleritis, and primary sclerosing cholangitis, particularly in ulcerative colitis.
Finally, what are your clinical management recommendations for this patient?
I recommend coordinating management between the patient's gastroenterologist and a rheumatologist. Medical therapies can include methotrexate, sulfasalazine, or biologic agents such as tumor necrosis factor blockers, which can treat both the active inflammatory bowel disease and the axial spondyloarthropathy.